and thank you for the invitation to come here. I need to set my time on because I will talk to you until tomorrow if nobody controls me. That's not good, right? So thank you for inviting and setting up this meeting, and thank you for joining. My name is Bogi Eliasen. I'm from the Faroe Islands, and we actually beat you twice in football. You know that? You forgot, right? Yes. No, you didn't. Okay. So, but anyway, I've worked with health for the last 10 years, very much with genomics. I set up the first nationwide genome project in the Faroes some 10 years ago. And for 5 years I worked in the Copenhagen Institute for Future Studies, where we work on how will health change with the new technology and how does that look. And I've been involved with this index also because we need a lot of data to work with. We need to see things differently. So I'm going to try to take you through why we're doing this and how we're doing this, and also look a bit at what is happening in Greece. Can you see the screen okay? Yes. Yes. What is happening here if you're not a researcher. So one of the things here was also to try to give an overview on what is happening in this place, and can we compare so we learn from best practices in different places, but also to be able to look at what is actually happening in the healthcare system. We agree on there is a paradigm shift coming, but we also need to change when we have new things. A lot of this is about democracy, so being in the cradle of democracy is quite nice, looking up there. But this is very much about also thinking, is this only to be systemic on organizations and states to do it, and how much should be personalized into people themselves? So what we do is that we have taken public picture, we have taken data that's available publicly, and then we have made an index that is much easier to access, much easier to compare. But on this, you can always go back and look where does the data come from and compare it. In the first part, we have a more general sustainability index where we look at what is the sustainability on each country. And the first year, breast cancer has been the focus. Now the next year, MS, multiple sclerosis, is the focus. So there's going to be a new focus every year. But when it comes to sustainability, which was mentioned in the beginning, when we look at the trajectories for health, there is no way we can pay the way we are working today. So we need to change. And the only way we can look at where to work with it is to be better on data. Yes, so as you see here, we have taken, we have 2,400 data points we have taken in from several ways, and then we have an expert panel that has been in working and advising on how can we work with these things. This is not a conclusive truth on health. It should be taken as an overview where you can dig more into what is happening. And I do myself think, of course, I am biased. I think it gives a very fast overview of what is happening on the part. So we have focused on the general index. We have focused on access, health status, innovation, quality, and resilience. So we can see on different parts of the health system. What we see is happening, not all over Europe more or less, is that there is a lack of access to some treatment. Some person needs something, and then you get something in the media, and then all the political attention goes to a specific small part of the health system. What we are trying to do is to have a more holistic view. Can you look more holistically on what is the real pattern here? What is really working? What is not working? And can we learn from the different parts? So when we come into Greece, we can see that on general, on this part, Greece is ranked 18 of the 28 countries. When we take all the parts, so it's a little bit below the average on that part. When we look at some things, we can see, for instance, nurses, midwives, and on that part is quite low on the numbers. But doctors practicing physicians is actually quite high. So it's a quite strange balance when you compare to other countries, that you have one group of healthcare personnel that's quite high, but other that is quite low. And then also when we look at what you have of equipment with radiotherapy, with operating theaters, and also gamma cameras, it's quite good. So to have the equipment is not the point here to be worried about. But the out-of-pocket expenditure is quite high. And when we go further on to, if we then use the out-of-pocket expenditure, the income-based healthcare is very low. So that's also some strange things to look at. What is actually in this system in that way? We see that on smoking, you really like to smoke.
Yes, we do.
So, and if that's an issue, I mean, that has to be put into it. When we see alcohol is not a big issue. There are some countries where alcohol is a huge issue on the health part, but smoking is clearly an issue here. But nevertheless, when we look at the different parts, the health status in Greece, which comes most on the longevity of people, is actually quite okay, on a 9th place in that part. So when we look at the sustainability index scores, you could say that on general, it's a bit below the average. When we look at innovation, it's actually quite low. And that also comes into that the budget for research and development is not very high. The way of working together is not very high. But this is, you should also have in mind that research and development in life science in Europe is very concentrated on a few countries, so that's also a part on it. When we look at the access, it's higher than the average, so it's easier to get access on several areas. And that's also because you, for instance, have a lot of doctors or healthcare personnel where that is. But for instance, genetic screening and, as said, nurses and midwives is very, very low. So that's an area which will be important in the future, which is not really in today. When it comes to quality, it's also below middle in it. And that's both the health-related measures, but the general life satisfaction goes a bit low, and happiness goes fairly low. I mean, when you smoke so much, you have so good weather, why are you not happy? I don't really understand that. So that's maybe something to consider. And then there is the long-stand limitation on health problems where there are a lot of people who don't really get the care that they expect on it. Resilience is fairly low on it, so how strong is the system seen on the future challenges that we see? So there we can see that there are some issues to work with. It's the future workforce that is challenged here. So when we look at the education also of physicians, it's very, very low. It's something that makes you worry, okay, how are you gonna survive with this system, also because the age of the general workforce and health is getting older, and the education part on it is not good enough on it. And then if we look at the health status, as said, that's fairly high on it. You live fairly long, probably because you are a lot together, you have better food than you do in Northern Europe, maybe. But also programs on the vaccinations are good on that part. And the NCD diseases is not coming as much through here as you see in other European countries, but that is probably to be a case in the future which you should prepare for, so you don't get into the same issues as we see in other countries. And it's also a low rate of diabetes, which probably has to do something with food and lifestyle as well. So Then what is the future of healthcare? So what we work a lot with in the Copenhagen Institute of Future is how will we work with future? How will we approach to these challenges? And what we can see is normal in all countries. You can probably not see the text, but it says healthy low risk, healthy medium risk, healthy high risk. So this is disease early stage, disease middle stage, and disease late stage. The way systems work today is that you only pay when we're here. There is no reimbursement earlier in the system. So it's very easy to go around and say that we want to work preventively, we want to work with early detection and early intervention, but as long as there is no money here, nobody's going to do it. So a new reimbursement system, so leaving the fee for service to some kind of value-based health is something that almost every country is trying to do, but it's very hard to do it. One of the reasons why it's almost impossible in most countries is because we have not focused on the needed data. We cannot make this change without going to data. But we do know that if we want a sustainable health system, we need to go lower on it. And the question here, which has been discussed in many places on that we get older, that's not the issue. The issue is that we get an increased disease burden. If we get older with the same disease burden or less disease burden because we work smarter, it's no issue. It's the disease burden, not the age, that's the issue on it. What we see in most countries is that a very small percentages, 1% costs around 30% of the health budget, 10% costs in between 75 and 85 depending on the country and how you calculate it. And this is just the health budget, not the social budget. So there is also a need to look at why are some of the parts so expensive, which countries are beginning to look at. Part of it is, of course, end-of-life care, where we want to treat the last months. But a huge part of this is also comorbidities, multi-diseases. How do we work better with that? Because multi-disease is very rarely combined, looked at, focused on the patient. So that's also a change that will be needed. What we see as necessary, so we did a big Danish scenario process with all the major stakeholders 2 years ago. And what they, public and private, what they concluded also was that if we want to work with sustainable health, we need to change the mindset of the payers, both public and private, that we move from health costs to health investment. So the health budget has to be seen as an investment for the lifespan. So we need to leave this what we call incident-based sick care, where you only think about the concrete clinical situation right now, to think about the lifespan of the person. So Finland is a good example where you had the health budget and the social budget combined in a ministry and on the budget for 30 years. So what you fail on the social part, you pay on the health part, and what you fail on the health part, you pay on the social part. So the incentives to think this together is different. So this is also what we see with private and public services on health, that it needs to move to lifespan if we want to have it sustainable. When we think about data today, it's what we call standard health markers. This is what we normally have in the clinical part, and this is what is the focus of most countries. But we are beginning to get different kinds of genomics or multi-omics. So different kinds of real-time expressions, biological real-time expression. And this is not a question about if it comes, it's a question about how do we get it into the system, because this already exists. And if we don't take the responsibility and get it integrated and take control of it, it will just come in another way. So if you want to be part of that development, it has to be on focus. We also discuss on real-world data and real-world evidence, where we have lifestyle markers and digital markers. And in most countries and health systems, they will say, okay, we probably need to discuss this, or we probably need to take it when it comes. But this is already here. Your smartphone, your Fitbit, your whereabouts where you can be logged, everything is already here. But we need to see this as a part of the healthcare and put it in. Is this easy? No, but this will come. So you can decide to let others come in with it into your society, or you can decide to make this a part on how you work long term. So, in conclusion, it can be said that sustainability needs data, and when we look at the Greek picture in overall, it's quite clear that there's a lack of data in the system. It's both on registries, where you have better registries, the combination, but it's also to focus on the individual in that part. There will probably be, and there you have a better situation than most countries to actually work ahead and to not get into the NCD epidemics that we see in different countries, so you can actually be ahead on that part. But also to move a focus from disease to focus on health. So what most systems today do is that they will help you once you have a disease, but they will not help you to avoid the disease. And that is going to be very hard on a longer term, only to begin to work when we have the disease. We also know that if we only begin when the disease already is in a clinical situation, it is more expensive and the impact is more difficult to have on it. And as I said, the equipment, doctors, is quite high. There's a lack of nurses, but the lack of focus on education is alarming when you look at these numbers. And if you want to go with the future of health, which is going to be data-based, which is going to be scientific with several ways of it, it's going to be very, very hard to do it without a high focus on education. But this is not just health personnel education, because this will need AI expertise. This will need equipment for different kinds that we will need in the health system. So data-driven health, it will come. For each country, it will be very, very important to actually have a stand on how do we take this, because the players around the world are quite big. All the big four horsemen, as we call them, from Silicon Valley, they are investing heavily in this, so they will come. We see the same from China. We also have four big from China. So if you don't take it from a local perspective and say, okay, how do we want to work with this? How do we want to have people to be interactive in this? And how do we want to work with health and disease in this way? It's going to be very hard to say how we want others that we cooperate with in this system. Yes, I think these were my words. And this is just a picture of me when I was a little bit heavier, but that's okay.
It's black and white, so it's cheating.
Yes, yes.
Have you considered the fact that many nurses left Greece to work in Scandinavia, for example?
Yes.
Many.
Yes, and
Because we have many schools for nursing, for nurses.
yes, yes, but the fact remains that they're missing. It's very low. Yes. And this is also something we see in other southern countries, but especially in Eastern Europe, that you have a lot of the educated people have left. Yeah. Yeah.
The European Commission and the OECD focuses a lot on reducing waste in the health system, so to help allocate funds in a better way. Do you think that is? Do you agree with that? Do you think that it's important to do that in order to look at the future?
Yes. So the way we see it from the Institute is that we need a sustainable health model. And the sustainable health model is going to be very hard if you don't reduce waste. But you only can work, it's a bit like the environmental part of it. If you don't have data, if you don't know what you're doing in different ways, you don't really know what the waste is. So this is the first part, but we can see on what is bought on equipment and different kind of things that there is waste. We can also see on the hours that we put in and the outcome on the health that there is waste. So there's no question on that. Waste is a part of it, but the only renewable, so I finished early. The only renewable resources we have in health is data. But if it is to be renewable, you cannot use this single-use mindset. It has to be more open. It has to flow. You can't put a control or ownership on it so you can reuse data. So it has to be both for the individual and for the system to learn from experience, so you can put it back. So waste is very much to have a data structure on it. Yeah. Yeah.
How can you persuade politicians to take action?
Yes.
Is it difficult?
I would not say it's easy. So we are working right now on a major Nordic project called Nordic Health 2030, where we have assembled from the 4 bigger Nordic countries, because the main stakeholders are just agreeing on that this is not going to work. We need to refocus. What is needed for the politician, and this is also one of the reasons why we make an index that is easier to access. So you need to show politicians that it's not about the single disease. It's also about the single disease, but it's not just about the single disease, but it's about seeing the big picture in this. But it's also about showing that if you really want to give the best health on a longer term, you need to focus on prevention on long term. But the big issue we have with politicians is that the election period is 4 or 5 years, so it can be very hard to get them to get into it. And in that part, it's not about just the politicians. It's also about the whole environment, the hospital, the research, even the insurance part to actually align on that we need to think in this way to get the direction. So I don't think there's an easy fix saying that now we have an index and we show it to the politician and it's done. It's a longer push on how can we do this. But it's easier to talk to politicians with this than without. Yeah? Actually, much easier. Yeah?
Ναι, θα ήθελα να... Είπατε ότι ζούμε πολύ. Δηλαδή δεν πρέπει να ζούμε. Είπατε ότι ζούμε πολύ. Δηλαδή δεν πρέπει να ζούμε. Και εν πάση περιπτώσει πώς πρέπει να αντιμετωπιστεί το πρόβλημα της ευζοίας.
Yes, I mean, it's always easier to say that everything is good and we don't have to do anything. But what I think is very important and why I stress the fact that the longevity is high in Greece is that everything is not in the health system. We know that if we want to change health on the long term, we need a good structure on nutrition, we need a good structure on housing, we need a good education. That's the most important thing on it. So it's not just the health part of it. But there are some issues when you look at Greece and other countries. One thing is that people who don't get ill live longer, but you still need to take care of people who get ill. And there we have some issues on that part. Greece is doing good on longevity, but is not on the total top. So there are still some improvements to work with on that way. But what I think is very important that if to push this forward is to have an improved health structure parts on it, think it holistically, but not forget the strengths in the Greek part of lifestyle, which actually is quite good in several ways. So it's not just to relax and say we don't have to do anything. I don't think that's a solution. But don't go totally in the way that the health system will change everything. It has to be about life quality, which has some strengths in the Greek part. Yeah.
Just a quick question on the access. parameter. It was surprising to see Greece doing so well on that. So can you just clarify, or if you can pull the slide up, where what was actually measured when you talk about access?
Yes, where was that? Where did we have the access part? Yes. So when we look at access, it's nurses and midwives, which is quite low. Unmet healthcare needs. So there are clearly some things, some people who don't get the care that they need. It's very low on newborn genetic screening, which most countries are beginning to have. And newborn genetic screening is very important on rare diseases, because some of the rare diseases you can treat immediately and there's not so much effect. And if you don't treat it immediately, you can't really do anything. The radiotherapy coverage, the out-of-pocket expenditure, which is quite high in Greece. Number of psychiatrists, hospital operating theaters, available technology, and practicing physicians. Those were the things that we looked at. And of course, there are other things to look at, but we have focused on these are probably the most important ones. Yeah.